2 days ago, a student sent me a multiple choice question from a study block that they got wrong. This is a really common thing to do. I encourage you to do it a lot. I like it a lot. It's a fun way for me to teach because the student is invested in the knowledge, right? They tried the question, they got it wrong, which really is bothersome. And then when they tried to understand why they got it wrong, they couldn't explain it to themselves. That's a great student to teach. Understand, this is one of my very best students. I don't know that I've ever had a student that knew more facts than him. And so he sent me the question and we started to go through it. And every time I'd ask him, what do you think the examiner meant by that? Because this is a clinical question, he couldn't answer. And I would have to stop and say, well, we can't go on until you understand this idea. This is one question. We finished an hour and 20 minutes later. And that leads me to a bigger idea I keep struggling with. I just don't think you can teach yourself medicine. I think medicine requires intense tutoring. And by tutoring, I mean you've got the knowledge and now I'm looking at you saying, why don't you explain that to me? And I can watch your body language and your hesitations and your confidence. And if I don't like that, I say, I just don't like how you did that. Why don't you stop and explain this idea to me? And so I can literally tease you out and really build all the areas where I think there isn't great understanding. So I thought, what a good thing to show you the question. And then we'll go through it. I'm not going to actually spend an hour and a half doing it, although it really would be fun. What I'm going to do is I'm going to show you all the places where there just wasn't enough information for him to continue. And you'll see that as we aggregate these pieces of information, you'll see why he didn't understand the question. Now, being a really good student, of course, he only needed it explained once. So here we go. Let's take a look at this multiple choice question, and you can imagine what it's like being tutored, because that's really why we're building this site. Before we get into it, if you haven't already, be sure to subscribe. Every week, we post a video like this, so you can learn and understand better how you're going to master learning medicine. My name is Dr. Philip Tisdall. I practiced for decades, and now I've been teaching for over 12 years. Really fallen in love with teaching. Hope you'll come and join the team. This is a multiple choice question sent to me by a really excellent student. I'm sure he knows more facts than I do, if truth be known. But what I want you to see is he couldn't get this question right, which is fine. I miss lots of questions. The question is, why did he miss it? And so we started to go through it together live. And what I want you to do is I'm going to show you all the ideas that he didn't have, because I want you to understand the difference between having lots of facts and having a clinical understanding of why facts are necessary. This is the oldest idea I keep harping on. Clinical medicine is built on a foundation of basic medical sciences. And I'm telling you, it just isn't out there. That's why I'm here. There were 1 million people doing this. Look how old I am. I got 1 million fun things to do. But the truth of the matter is, connecting the clinical to the basic sciences, really, there's very little of it. And I want you to use this multiple choice question and compare how well you could do it. So I'm not going to spend the hour and a half he and I spent together going through it, but I'm just going to outline the thinking and ask yourself, do you have this idea in your head? Okay, let's start with our question. I'm going to read it just to save time. A 60-year-old woman comes to the emergency department with shortness of breath, productive cough. Let's break that down. 60 years old. Yeah, when I don't want you to be able to use age, I kind of use 40 to 60, because over 65, degenerative malignant, middle-aged women, autoimmune diseases, less than 25, congenital hereditary. So 60 is kind of oldish, doesn't drive my prevalences very hard. Woman, got it, female reproductive, but remember, atherosclerosis is so overwhelmingly important in the Western world, you have to just factor that in. Women get that nice 30-year hiatus from estrogen, so -1 atherosclerosis. I like it when they include the site of care delivery. It doesn't change prevalence a lot. It's what I call a colorizer. It gives you a sense of seriousness and urgency in the patient's mind. If you're going to all the trouble to go to our nasty ERs with hours wait and people all crowded around you, you're really in trouble. And here we have our chief complaint. So that's a really big deal, because now all of a sudden I can do the differential of shortness of breath. Remember, it starts with organ. Did you throw a couple of diagnoses out there? Then you're not right. And look at this, and a productive cough. Okay, I like cough a lot. If you've got cough, we're in lung. But here's the snag. Productive. Great adjective, right? Coughs are productive, non-productive, or hemoptysis. But when you say productive, what does that mean? And all of a sudden now we have to break out to, how do you think about the lung? When you saw cough, did you go bronchial tree ventilatory, alveolus respiratory? Did you do that? Because boy, where that cough starts really matters in that differential. And the problem with productive is with what? Because productive just means a fluid. Is it mucus? Is it pus? Is it blood? Well, they didn't give it to you. Is that because they're not very good or because they just want you to work a little bit harder? You know, when I want to make a question harder, I leave stuff out. You can't leave out essential stuff though. That bugs you. Patient has a 30-pack year smoking. Yeah, okay. So with my student, we had to stop and break out, how do you think about the structure function of the lung? Because I break it out, ventilatory is 3 units, laryngotracheobronchial, bronchi, bronchioles, and then the alveolus. So we had to stop and talk about that. And then we had to talk about how that looks by the auscultation, because that's going to be important. And then all of a sudden, here's smoking. So can you take smoking? Let's just take a look at this. So as I'm just going to draw how I do structure function lung, okay? Okay, so that's how I do structure function lung. You can see I break it into ventilatory gas exchange, right? So here's my laryngotracheal bronchial, here's my bronchi, here's my bronchioles, and here's my alveolus. I just tell you, when you do this, everything just becomes so easy. So you have to be able to talk about how do all these vary by structure. Not going to go into today, but if you can't tell me, you need to. Then we're going to say, tell me how this breaks into auscultation. Well, that matters, do you think? Because this is where we're going to get stridor. In the bronchi, this is where we get rhonchi. Can you discuss those? This is where we get wheezing. So if your patient's wheezing, you're in the small airways. You know, what can I tell you? And if you're in the alveolus, you hear crackles. So right off the top, you can imagine, wow, I mean, if you can just do that, your physical exam is talking to you. And then what we can add in this case, I want to add in, tell me about smoking. Because it's going to affect each of these down here, right? Because in the bronchi, this is where I get my mucus production. So this is the coughing from chronic bronchitis. In my bronchioles, this is where I get my respiratory bronchiolitis, which is going to be one of the really important progressive causes of death. And down here in the alveolus, this is where I'm going to get my emphysema, which has its own pathophysiology. Okay, so look at this now as we're walking down this history, right? I can say, I now see she's smoking. Good. The next thing you got to tell me is, tell me about smoking and COPD. Is 30 a lot? Well, you just got to have a rule of thumb, right? Here's the basic rule of thumb. If you're less than 10, you're a marginal smoker. If you're in the 20 to 30 pack years, that's serious risk. What does serious mean? Well, if we're just doing COPD, yeah, this is going to be 25%. So even serious smokers, it's not like they have to get COPD. Most don't. If you're talking about what's the likelihood of cancer, this is going to be in the 15% range. So you sort of think smoking cancer, for sure, doesn't mean you're going to get it. So when we say 20 to 30, that's a risk factor. It's not causing anything. Got it. Okay. On physical exam, she's using accessory muscles. Well, sure, we know that because here's my SaO2. And now we have to stop and talk about, tell me about why we care about SaO2. Well, you're going to need this picture in your head. This is the picture of SaO2s. Here's my SaO2. There's 100% saturation. Here's my PaO2, and here's 100% millimeters of mercury. And when we say, good, what draw me how they relate, it looks like this. Yeah, this is the first time in your life you really cared about the oxygen binding curve that you've memorized 1,000 times in physiology and never really knew why you cared. Well, it turns out it does matter, because when we say, what is this point right here, that's 60, and what's this point right here, that is going to be 92%. This then becomes a critical point. This is your ICU point, meaning you're going to defend this oxygen level in your patient Because if you don't, look how fast they get hypoxia. So that's a big deal, right? So now we have that nice little choice fact. Let's come back and look at 88%. She's in respiratory failure. And now we can say, okay, she's in respiratory failure. Oh yeah, accessory muscles. Didn't add more information, but it's nice to have belts and suspenders. Good, that really fits. She looks like she's struggling, and we can see that it's actually failing. That's very helpful. So this suddenly becomes very serious. And now we're talking about she's kind of getting into the serious admit to hospital group. Oh, wow. Let's go to auscultation. Oh my goodness. Yeah, well, right. Oh dear. So where are we? We're here, aren't we? We're in small airway disease. That's very helpful because wheezing equals bronchospasm. We haven't got time to go into the structure function of that, but it follows perfectly from structure function. Got it. You got a patient respiratory failure. You're going to defend the failure point in, if you're using SAO2 as a 1992. So you put her on oxygen. And what happened? Oh dear, she fell to pieces. We have altered mental status. So that's a really nice story. Smoker comes in having trouble breathing, you put them on oxygen, and they have altered mental status. So why? Perfectly great question. Well, now we have choices. So now what you have to do is you have to say, do you understand what happened here? Because you now need a few more facts. If we talk about COPD, we have to break it into our elements, right? And our two fundamental elements are going to be the bronchi, which produce mucus, the bronchioles, so that's our mucus, that's our chronic bronchitis. Bronchioles, remember, these get bronchospasm, and anytime you're putting irritating smoke down there, of course, that's an element of it. And then in the alveolus, we're thinking about emphysema because we're losing septum from the inflammation and the elastase. So if I was going to say to you, how do you think about COPD? This is how you should think about it, right? Here's my chronic bronchitis, here's my emphysema, and here's my bronchospasm. Well, for my student, he thought that was asthma. Well, I get why you said that because you think of wheezing and bronchospasm as asthma, but it's also part of COPD. And if you didn't have that, this suddenly becomes a problematic question, doesn't it? And you say, well, what makes this COPD? This is what you're going to do. It becomes COPD when your FEV1 is less than 80%. So you can see you have transient bronchospasm and you have permanent bronchospasm. Well, if you're kind of missing that element of your COPD, this is a harder question, I'll grant you. So here we are. How do we think about COPD? So what happens in COPD? Again, it's this universal picture. Here's my alveolus, and here's the blood supply. Yep, sorry, I just got to check and make sure you got it because so many of you don't. So remember, here's my O2, and here's my O2. That is ventilation-perfusion matching. Fundamentally underlies almost everything you see for shortness of breath. So what happens in COPD is we are going to decrease ventilation, and therefore we are going to get vasospasm, so we maintain our VQ match. Lung is the only organ in which hypoxia causes vasoconstriction. Every other organ, hypoxia is vasodilation, right? Okay, so let's come back to our question. So we've given oxygen. What's that going to do in the lung? Well, it's not going to increase pulmonary vascular resistance. It's going to decrease it because oxygen is going to cause vasodilation. Is oxygen going to create reactive oxygen species? Oh, absolutely, for sure. But now you got to get a time frame on that, right? So if we're damaging proteins, damaging cells, damaging tissue, how long do you think that takes? Well, not minutes, right? We agree. Tissue takes, weeks, months, years. So no, got it. There's reactive oxygen species. Doesn't fit our time frame. Renal bicarbonate. Sometimes you just have to have answers to fill stuff in. So, if you're talking about lung, every student is happy with breathing and renal compensation and metabolic acidosis and respiratory response. So I think this is just looking for, were you just sort of generally reading and thinking about, wow, breathing, kidney compensation? I think that's sort of a filler one. I can't make that work in any way. So now we're down to 2. Okay, respiratory minute ventilation. Okay, well, first of all, you got to know what that means. It's kind of this is where physiologists just overwhelm us, right? Because all this is tidal volume times respiratory rate. How much air are you pumping? Not as useful as you'd think, right? Because it doesn't tell you how much dead space there is. You really want to know how much air is going to the alveolus, because that's where your gas exchange is going to occur. I mean, does anyone really need to know that parameter because opioids don't suppress breathing? I mean, do you really need that idea, or is it kind of self-evident? So be it. It's tidal volume times respiratory rate. Does that relate to this? Well, I haven't seen anything that says respiratory rate or depth of breathing. You know, most clinicians are pretty good watching you breathe. You know, if you're over 20, you're starting to increase your respiratory rate. If you're over 30, you're really puffing. And then you can say, how deep is it? So most of us have a pretty good intuitive sense of this, and that isn't in the question. So I don't know how it would apply. So that leaves me with a VQ mismatch. Well, that's pretty interesting, isn't it? Now, if you have a bad idea, you'll come back and make your case for this, and that's what the student did. So let's take a look at what really happens when you have COPD and you introduce oxygen. Shall we do that? Okay. So remember what COPD is. It's going to be obstructive. There is decreased ventilation. You don't know that. Well, we have to go back to the beginning and talk about the pathology of this, but let me stipulate that for me. Okay. So there's my decrease in ventilation. What that means is there's nothing I'm going to do that's going to make it easy for me to get that CO2 out, because CO2 diffuses really rapidly through cell membranes. So getting your CO2 from the vessel into the air, never a problem, right? 20 times the rate of oxygen. That's never the rate limiting step. But ventilation, the ability to blow that CO2 out, yeah, that's the problem here, isn't it? So look what we've done. All we've done is added pure oxygen. Have we in any way changed our ability to get rid of the CO2? Answer, no. So what's happened in this patient is we've introduced O2, so we've done this. We've caused vasodilation. So there's no change in ventilation of the CO2, but we've really increased the perfusion. So what we've created, 70% of this patient's symptoms are because we've got a VQ mismatch, because you're increasing the CO2. The other problem that you face here, another probably 25% of this, is because remember, CO2 is carried on hemoglobin. And when you bring in the oxygen, it displaces the CO2. So when I know that story, then I can come back here and say, okay, here's what's happened. I've got a COPD patient. I've introduced oxygen, and I've got VQ mismatching, and I've got Haldane effect, the ability of O2 to outbind CO2 on hemoglobin, and that's giving her hypercapnia. And that's why we're seeing the altered mental status. That makes great sense. Okay, the student comes back and goes, but wait, we know that respiration is driven by CO2, pH really, but CO2's pH. And then there's an oxygen in our carotid sinuses. So didn't we just introduce oxygen and turn off the breathing impulse? And that's a really standard answer. And the answer is, nope, that's wrong. I know you're going to go crazy out there. I did too. Go look it up, walk through the argument. The answer is no. And when you think about it, that makes really good sense. Because supposing there is an element of that, right? I've increased the blood O2. I should have shut off the O2 center, right? Yeah, what happens 2 minutes after you shut it off and you stop breathing and O2 goes down again? So how could that be sustained decreased breathing? The answer is, well, it isn't. So if you want to make the suppression of breathing center, the answer is that is not true. The answer is we are getting a VQ mismatch because pulmonary vessels constrict with hypoxia and dilate with oxygen, and we haven't changed ventilation. So that's just a quick walkthrough. On any of these, we can pursue the structure function discussion. We can talk about Haldane effects. Look at all the areas we could have talked here. I've just sort of pointed out areas where even you listening to my story, I couldn't continue because you needed a little bit, or my story wouldn't even make the slightest sense to you. So what's that taken us? 20, 25 minutes just to introduce the ideas of this one question. Okay, that said, I don't think this is a good question. And I'll tell you why. Because all they gave me was smoking, a 30-year pack year of smoking. They didn't tell me she had COPD, right? She didn't. How do I know this patient has COPD? Answer is, I don't. All I have is a risk factor that 25% of her with that pack year would have COPD. I don't think that's fair. I just don't. That's what I call a read my mind question. And understand, that's not a criticism. I write a million read my mind questions. You don't know how good a question is till you put it in front of the student and you find out what was perfectly obvious to you when you wrote it. Turns out it isn't so obvious to the reader. So I think this would have been a better question if they'd introduced this as COPD, and then we can talk about the shortness of breath as an acute exacerbation. Because you can see, we started talking about COPD and we talked about how to think about it pathologically, but did we talk about how to think about its natural history? And I got to tell you, collectively, medical students are terrible at this because they so focus on diagnosis, they don't stop and say, now imagine sitting in front of your patient and explaining this. Because what you've got to be able to talk about is the patient's concerns now, which is what we call natural history. The first thing your patient's going to say is, what happens to me? Well, that's going to be prognosis. Yeah, no kidding. The next thing is, well, is there any problems with this? Well, for sure. We have to talk about complications. And then the last one, perfectly self-evident, is there anything we could do about it? You mean treatment? So that's a really easy area to forget. And what we're talking about today is this. If I said to you, what are the acute and chronic complications of COPD? I doubt half of you could tell me based on my experience with y'all. So what's the acute one? Acute is called acute exacerbations. It's really a thing. It must be half of all your COPD patients will die of it. If you have an episode, you have a 25% dying of your COPD in that year. And yet none of you have heard of it because it doesn't have a crisp diagnosis and it's clinically based judgment to establish it. But clearly really important to talk about. And that's what we're seeing here. And then when you say, well, what do you die of in this? The answer is, well, cancer. We can all do that, right? And then we talk about the respiratory bronchiolitis. Never met a single student ever who'd ever even heard of it. And then the last one is cor pulmonale. We're back now to this oxygen, vasoconstriction, pulmonary artery hypertension, right ventricular failure. So you can see we didn't even get into COPD today. But I hope in looking at this question and hearing this story, so, well, I guess I'd like to spend an hour and a half just teasing out all the areas in here that would just make me better. And the answer is, I really like doing it. It's really fun to do. And you're really motivated, especially when you up and say, well, this is a terrible question because they don't establish COPD and their presentation of acute exacerbation is just read my mind. So that always makes you feel better that you miss it. But the ideas are good, aren't they? So a big thing we're going to do in our community is send in your questions. And, two things will happen. Either you don't know it and then the explanations are really helpful, or I don't know it and then you get the joy of watching me go on a big rant about why it's not a fair question because I got it wrong. So bring your questions in. They're really fun to do. Sort of when I don't have anything good to talk about, I always go, give me a question. I do it all day with students all over the world. And that's what tutoring looks like. If you think that's useful, better come join the community, right? If you want to keep building your clinical skills, why don't you challenge yourself with our multiple choice questions and see if you understand what we mean by the word clinical. The link is in the description. And you can believe me or not, but you do need deeper teaching, deeper guiding. Let's call that tutoring. So that's why we're building the website. Come and see for yourself. I'm teaching online weekly now. Would love to see you there. You can learn more at drphiliptisdall.com. See you next time.